Hi, this is QD Clinics. I'm David Liew from Melbourne, Australia. Just another one from earlier in the week. I see a lot of patients who have had arthralgias and myalgias in the context of having cancer immunotherapy. And this is relevant to that because in those patients, we're often even more cautious than we would be in an ordinary situation about giving glucocorticoids, about giving prednisolone. We worry a little bit that that could potentially dampen down the cancer immunotherapy response. That's something we're very cautious about because the last thing we want to do is dampen down potentially life-saving medicine. Of course, oral steroids are something that we shouldn't just be throwing around in the first place. And so this is all relevant for this patient. So he's a 75-year-old man. He has metastatic melanoma, and he's being treated with nivolumab, which is a PD-1 inhibitor. He's about 4.5 months after having had the first dose of nivolumab. And his oncologist has sent him across because they were worried about the possibility of polymyalgia rheumatica as an immune-related adverse event. Because this man had been having pain over both shoulders. They've really been getting in the way of things, had been waking him up at night and had been really bothering him. They were worried that it was going to be a problem for the cancer immunotherapy, especially, and they're worried he was looking pretty miserable. And they wondered what to do. And whether, in fact, they were about to start prednisolone, but they thought they'd call me first. I think that's always a good move. So really, this shoulder pain, definitely on both shoulders, both lateral shoulders, had more of a mechanical feel to it. Certainly didn't really seem to be a lot of, he'd been stiff right throughout the day a little bit, but the stiffness certainly seemed to get worse throughout the morning. The pain certainly did seem to be mechanically triggered as well, although it certainly was painful when he was lying on his sides at night. And critically on the physical examination, and I think this is where our skills as rheumatologists are what helps other specialties. For him, it was interesting that if I abducted his shoulder, then that brought on the pain from about 60, 70 degrees of abduction. But flexion was certainly, passive flexion was perfectly fine. And in fact, he had positive impingement test on both sides. And really what he had was bilateral subacromial bursitis rather than polymyalgia rheumatica. So the good news is that I was able to give him corticosteroid injections into both subacromial bursae, local anesthetic effect, woke up out a very happy man, and I called him last night, and actually he's still doing very well. Didn't need to give him any oral steroids. Didn't even need to give him any systemic steroids. And really that means good things for him in general, good things for the cancer immunotherapy, doesn't have polymyalgia rheumatica as an immune-related adverse event, and now is able to sleep. So I think that what that teaches us is that, of course, as rheumatologists, we're still very dependent on our physical examination. Some of this can be done through telehealth, of course, but when you've got that video there to be able to see movements, it's not always easy over video, but certainly getting to do those shoulder movements is critical. Abduction, so in polymyalgia rheumatica, we don't see certainly classical polymyalgia rheumatica and seemingly polymyalgia rheumatica as an immune-related adverse event. We don't see problems always. So we do see problems with both abduction and with flexion of the shoulder. Whereas sometimes with mechanical disease, depending on exactly what we're looking at, with shoulder tendinopathies, especially when they're really the subacromial bursitis driving things, we don't see issues with flexion, but we certainly do with abduction. Good lesson about the power of physical examination. Keep on joining us for all of October, where it's PMR month at Room Now, because we have to make room for PMR.